the case. This is a case of 43-year-old male, presented with nasal blockage and nasal bleeding since 5 to 10 years. He has previous face surgery in 2010 and another 2016. The biopsy report of previous was inverted papilloma. Nasal endoscopic findings of mass in the left nasal cavity. And the CT scan and detail discussed by sir.
Before the session will be proceeding for the surgery, I request Dr. Satish Jain to chair the session as a chairperson, and Dr. Abhishek Bhushan to chair this session for the inverted papilloma.
Hello.
Yes, sir. Yes, sir.
Yes, sir.
Yes.
So, coming to the end of the session, this is again a very interesting scenario. A biopsy-proven case of inverted papilloma, which was operated for sinus surgery and post-operative. The surgeon came across surprise intraoperatively, took a biopsy and turned out to be a tumor, inverted papilloma. This is how most often such cases are diagnosed. The reason is inadequate radiology. See, these tumors arise in the depth, then push out of the sinuses, pushing the mucosa in front, appearing as polyps. When we look the CT scan for the polyps, we have to focus on various aspects, and we can pick up such tumors on the basis of suspicion, and then further radiology can prove this. Say this, on CT scan of this case, elderly patient with unilateral disease with ballooning out of the middle meatus. See how the middle meatus is ballooned out. That doesn't happen in a regular polyp case. Then something is ballooning out, and see behind that. Can you see this in the maxillary sinus, the difference in this sinus and this sinus? Multiple conical projections. See this? This is where the tumor has invaded into the bone. This is a benign tumor, has a tendency to invade the underlying Haversian system of the bone. And this is where this is arising from. See, it has invaded the Haversian system, and this presents on CT scan by various ways, by conical projection, by bone erosion, by nodular projection, whatever it is. But this shows the site of attachment. This is a benign tumor like JNA. If you remove it completely, it cannot come back. If you leave it, it is bound to regrow and has a potential of malignant transformation in certain group of patients as well. This is notorious. So the CT scan can give you suspicion, but you never know what it is on the basis of CT scan alone. Then comes the role of MRI. Can you see the MRI here?
Yes, sir.
Are you getting the MRI on screen?
Yeah.
This tumor, as the name implies, inverted. The stroma, the epithelium goes back into the stroma, and it presents as laminar hyperintense and alternate hypointense bands. Hyperintense is the tumor. See this? Hypointense is the mucosa, on contrast. And if you follow these laminar bands, if you follow them in the deep, is the site of attachment. This is called cerebriform convolution patterns, quite suggestive of inverted papilloma. So MRI is again the investigation of choice for these lesions for very many regions. Number one, for the diagnosis. CCP, this laminar alternate hyperintense and hypointense band, is quite suggestive of papilloma, inverted papilloma, number one. Number two, where they are arising from. If you follow these laminar bands, where they are going to the bone, is the site of origin. This is the next information we want in papilloma, so that we can remove the underlying bone completely, thoroughly, radically, whatsoever, so as not to leave a trace of tumor to come back. So this another information is best given by MRI. Third is information in the tumor. Suppose you are operating on a biopsy proven case of inverted papilloma. In the depth, malignancy starts where even the surface biopsy doesn't pick up. You remove the tumor and the entire histopathology post-operative suggests malignancy, then again you have to go back. Because for malignancy you need an oncologically sound procedure, which is not done previously because we didn't have a diagnosis of malignancy. So MRI has the best chance of picking up the malignancy in the depth. See the tumor in the depth here, where it is arising from. If there is malignant transformation, you would find the necrotic component starting in the depth. Necrosis means the tumor has transformed in the malignancy, and that starts in the depth. So even the surface biopsies do not pick up. So the MRI can pick up the necrotic area suggestive of malignancy, and if it is, you have to plan your procedure accordingly. Even for such malignancies invading the walls of the maxilla, even endoscopy is the standard procedure for this. Still, if it is going beyond the confines of the maxilla, coming in the anterior soft tissue, orbit and all that, then you need an open approach. But only when you have a confirmed diagnosis. So on the basis of MRI with a necrotic area within, you can be prepared to deal with the malignancy by means of a frozen section, prove intraoperatively, and do the same radical procedure at the same stage, rather than cutting a sorry figure and a post-operative diagnosis and go back. So this is the value of, MRI in inverted papilloma. So single most important investigation in inverted papilloma to give you maximum details is MRI, not the CT scan. CT scan can give you only bony anatomy and some conical projection, that's it. Any questions? Accordingly, the approach is planned according to the CT scans. Suppose this tumor, at this tumor when attached to the turbinate only, the medial wall only, the lamina only, why would go laterally and do a Denker's approach? This is far laterally attached. You need a complete exposure, like in the previous case, we need a complete modified Denkers, endoscopic modified Denkers to reach out to that area so as to drill the bone completely to remove the tumor radically of the bone. And the second advantage of Denkers is afterwards the follow-up. Once you flush the maxilla with the nasal cavity, with endoscopy, you can follow up in your OPD for any possible recurrence. So that's the biggest advantage of modified Denkers in such procedures when the tumor is attached far laterally. Now there are different, prognostically different sites in papillomas. Frontal sinus always complex because you need a radical procedure, and endoscopy in that area reaching out is difficult. Now with the draft and other modification, it has become much easier, and still endoscopy is the treatment of choice. Sphenoid sinus, we have removed massive papillomatosis attached to the various walls of the sphenoid, attached to the carotid artery wall, attached to the optic nerve wall, and you have to radically remove the underlying bone to give a cure. And in sphenoid, you can imagine the complexity. Removing the bone over the carotid artery, bone over the optic nerve, we have done many a times to give a radical cure. Otherwise, there is no other way. There is no other way. If it has gone into the bone, you have to radically remove the underlying bone. That's how our papilloma are treated for the cure.
In some cases, while the MRI suggested.
Pardon? Can you speak a bit louder?
Sir, in some cases, while the inverted papilloma is a diagnosis, clinical radiological diagnosis, and even in the frozen, it shows the doubtful status of malignancy.
So I told you, the malignancy starts in the depth of the tumor. A surface biopsy cannot pick up malignancy. So for all papillomas, we must have a frozen section facility. While operating in the depth, if you have a slightest of the doubt, send for frozen section from depth to pick up malignancy. Then only you can pick up malignancy. Surface biopsies will never pick up. Malignancy doesn't start on the surface, starts in the depth.
Boss, everything is ready. Just wait for 2 minutes.
Done, done.
Almost set.
And also invite Dr. Satish sir for the banquet after finishing.
He has
Just
refused.
if he can be able to come for the banquet.
He has to attend some marriage. I have asked him already. सर ने तो लंच भी नहीं किया.
Dr. Rajiv, kindly show the endoscopic picture. Meanwhile, show the endoscopic picture and the findings.
Hello.
Yes, sir.
Actually, they have changed the endoscopy system. The previous one was tired. So, abhi they are restarting it. Just hold for a minute.
Done, done.
बहुत सेक्शन आएगा 5 मिनट लगेंगे.
एक सेक्शन ये नहीं चल रहा सेक्शन. हाँ जी रावत जी
1 मिनट रुक जाओ, वो सेक्शन 5 मिनट लगेगी.
चल रहा है सर. एक तो है.
एक
3 है ना पावर सेक्शन. तो उनका तो आ गई दूसरी भी आ गई. एक्चुअली ये अपने इंस्ट्रूमेंट्स पे नॉर्मल.
स्ट्रेट. अब ठीक है. स्ट्रेट. हेलो हेलो.
Yes, sir.
हेलो.
Yes, sir.
क्या कर रहे हो एक ही चीज को इतनी देर में?
We have a striker 4K camera also, sir. If you wish, that has a very good resolution. Sir.
Hello?
Yes,
Gauge
sir.
piece, gauge piece. नहीं वो भिगो ना रस्सी बना पेपिलोमा है यार इसमें से एड्रेनलिन था इसमें वो मिला ले थोड़ा सा पानी चलो हेलो
Hello.
yes sir
Yes, sir.
are you getting the picture there
Yes, sir. We are able to see.
so this is the initial endoscopic picture showing just polypoidal things in the nasal cavity. See this? We know from the imaging the kind of tumor it is and where it is coming from. See this?
Yes, sir.
The tumor has attachment far laterally and deep into the bone. And this is what the tumor which is prolapsing here. Find out. So that's the luminant component. Hope the picture is good there.
Yes, sir.
सक्शन तो ऑन करे यार 1 घंटा हो गया कहते थे See, I am removing the tumor from the lumen going towards the attachment. See this? In the maxillary sinus. See, this mucosa is clear.
Yes, sir. Satish, sir.
There is no attachment here. Yes, yes, dear.
Yeah, sir. Dr. Professor P.K. Rathod sir is here to moderate with you.
Sir.
He was a professor in HOD at Maulana Azad Medical College, New Delhi.
Sir,
And right now he will interact with you. Thank you, sir.
sir.
Hello.
Pleasure having sir here.
Good evening, sir. Good evening. Dr. Satish, you are looking at the picture, endoscopic picture. So it is a recurrent or residual?
It is always residual.
Always residual.
This is a benign tumor. Whatever left during previous surgery has regrown. See this? And now after this luminal component polypoidal tissue wall, see this is the tumor attached to the lateral wall. See this? Tumor has tumor vessels also. See this tumor? And in order to remove it completely, the visualization is must. And see this hidden area far laterally cannot be visualized endonasally. So this require a classical, like previous case, the suction rakhiya. An expanded approach, that is modified Denkers. Stunman can field approach. Or there. So the lumen is absolutely clear. We have to focus on the attachment that is far laterally. So that is the complexity. In order to reach out far laterally, you have to do lot of exposure. And then we'll see, we'll show you how the tumor is invading the underlying bone. Unless and until you don't remove that bone, however number of times you remove, it is bound to come back. So this tumor has a tendency to invade the underlying bone, and if recurs, not removed adequately, recurs again and again, can transform into malignancy in certain percentage of patients. So this is about luminal part. Now quickly for the modified Denkers, you have seen during previous surgery the steps of the modified Denkers. So this is अरे क्या है यार, चालू तो करा, कहाँ है कॉबलेटर, तो बंद पड़ा है. कुछ नहीं, ये देख करंट ही नहीं है. करेगा काम. So I am going to remove this mucoperiosteum of the lateral wall of the nose and then anterolateral wall of the nose. Quickly we discuss in detail about the modified Denker step in the last case. So now we know it. That is the anterior aperture. See this? That is the level of the pyriform aperture. This is all pyriform aperture. We have to go high up to the level of the orbital floor. This is inferior turbinate, has to go. Suction. This inferior turbinate has to go thoroughly as a part of lateral wall. This inferior meatus up to the level of the floor without wasting time.
Dr. Satish, what is the superior limit of this approach?
Orbital floor.
Orbital floor.
Yes, sir. So I will show you the level of the orbital floor from the inside of the maxillary sinus to see the superior limit. Okay. Now periosteum. I will elevate the anterolateral wall. This is the pyriform aperture here. Then I am elevating this from the anterolateral wall. This tumor is attached far laterally. So we have to go far laterally as well. ध्यान दे इधर यार रमेश. Suction बंद यार, end time पे ऐसे क्या कर रहे हो यार? Who stopped the suction? बंद नहीं करो. See the anterolateral wall? This is all superior alveolar nerve, neurovascular bundles. This is how it is exposed. And now we will remove. First, we'll enter into the see, the thin bone can be punched out, the anterior most. Rest we will drill off.
Sir, again we will follow the same thing, like thinning the bone by drilling and then.
Yes, same. See this? The bone is so vascular. सेक्शन कर दिया कर पीछे पीछे पीछे. Now we'll open the cavity में section कौन करेगा? Yes. Now. अरे यार हटा दे इसको. Gauze piece, remove the gauze piece. Can somebody start the irrigation? नहीं वो drill वाला section. यार एक जना यहीं खड़े हो जाओ यार इसको.
Dr. Satish, you are using coarse diamond drill, bar point,
Coarse diamond,
not cutting.
not cutting at all.
No, why not using cutting on a bone? Personal preference.
यार रविश पहले करवाना था. Is there somebody from Medtronic? See this? I am opening into the interior wall. This is coarse diamond bar. I am using at 65,000 RPM now. And now I am in the maxillary sinus. See the tumor?
Yes, sir. It's visible.
This tumor has tumor vessels in the depth where it is taking origin from. We'll show you. So we have to radically remove that origin. I am thinning out this bone and going up towards the roof. You have seen all this in the previous case, so I am going little quicker.
Sir, Satish sir,
Yeah.
sir, you usually use this precision hammer. I think,
Pardon? Anand, there is a lot of noise in the theater. Can you speak a bit louder?
Sir, in most of the cases that we saw operated by you, you use the chisel and hammer to just hammer it out in 1 or 2 strokes.
Yes, yes. That is a fast but crude method.
Yeah, but now you are using.
Yeah. Because this is the standard teaching. This is more precise. I would have been through by using the chisel and hammer by now. A very fast method.
Cancer, and we learned from your videos that using the chisel and hammer.
Yeah, that is very fast.
Yeah. So there is no preferences for the surgery, sir, no? Like where to use the chisel or where to use the chisel.
Now, see this, I am removing this, thinned out this bone, removing this, and see the nasolacrimal duct behind. That's the nasolacrimal duct. And we have to circumferentially uncover it. See the duct in the center of the field?
Yes, sir, we can appreciate. So we'll follow the same way like we did in the last case for cutting this plate.
Yes, the approach is same. Wash kar. Give me a good wash. Kar. Now see. See, the rest of the maxillary sinus is clear? Except this area here, where the tumor is attached, and we know from our scans. See this? So see the way of debriding. Go within the tumor. This will allow the tumor jumping into the blade wherever it is not attached to. And rest is the site of attachment. See this?
Yes, sir.
This is the level of the orbital floor now. You can see all around. We'll take biopsy from the depth. See the duct is marsupialized from all around. Exposed. Focus. See now, and now we will cut it flush. Cut it flush. See this? That's it. See this?
Hello, sir. Your voice is very.
Yeah, we have cut it flush. Pani drill ka. See the duct now?
Yes, sir.
That's it. Now we have to improve the exposure laterally. इसको क्यों करा? Laterally कर. Retract कर. See the tumor is attached far laterally. Without this access, you cannot reach out the tumor.
Dr. Satish, by this approach laterally, how much we can reach? Coronary, can we reach by this?
Hello? Laterally?
Laterally, to which extent we can reach by laterally by this approach? Suppose
Is
the
the
tumor is going from here to the coronary process, etc. Can we
yes, easily.
coronary, medial,
Yes,
the mandible?
you can go all around 360 degree. Earlier, the limit was this neurovascular bundle infra-orbital, but nowadays we can transpose that easily, preserving that, and you can go beyond that. See the anterior wall periosteum which I am stiffening? And now this bone has to go to reach out further. This bone. Chisel. See, this is the safe area now. Yes. सिर पकड़ना. Quickly you can remove the bone. अरे यार स्लिप हो रहा है. Sorry. Remove this bone. Wait. See this improving exposure. Debrider. Wash करते रहा. Now अरे इधर उधर लगवा. अब ये टच हो गया ना. देखो कहाँ पे. because आएगा अंदर इधर इसको रिट्रैक्ट करके see this tissue it's all papilloma. See, head on approach. See, work in the center, so allow the tumor to jump into your blade wherever it is not attached to, occupying. That will jump out. लेंगे अभी depth से. We have to remove this far lateral infratemporal fossa wall where the tumor is attached to. See how complex the area is. Impossible without Denkers. Cobblator first. Defining the bony limits.
Sir, we will require more bone removal to exposure.
Pardon?
Do we require further bone removal or this exposure is sufficient?
Yeah, there's still a lot of bone removal. This is within the bone. The tumor here is within the bone. See here.
Yes, sir.
Unless and until we don't drill away, there is no fun in operating. Drill. Ah, the entire lateral bone is deeply infiltrated.
Temporal fossa and infratemporal, दोनों are
No, no, not going out. Not going beyond the confines. The bone is invaded. पानी यार एक जना 25 जने हैं उल्टी में एक जना पानी बढ़ा दो यार ये बढ़ा ना ऊपर और हमेशा मत डालना जब विजन स्पॉइल हो ना then only चेक करना extensive drilling cobblator कोटरी लगवाया ड्रिल कर ट्रैक करके रखना see more and more lateral exposure
also will be going to the towards the palate.
see there's more and more lateral exposure, will uncover. Cobbleter. See this much of the tumor. लूंगा सर डेप्थ में. क्यूरेट भी रखे. Give me 40 debrider. वो पानी के लिए फिर बुला ले यार उधर सामने. सर एक जना को पानी के लिए बुलाओ ना सर, इधर चालू करने के लिए. कॉबलेटर एक जना वहाँ खड़ा चाहिए बस, या नहीं खाली कॉबलेटर पे खड़ा रहे जब मैं कहूँ. जब see this
Yes, sir.
within the maxillary sinus, lot of papilloma occupying. We have to make sure where it is attached to. Occupying is different thing, attachment is different thing. And see this mucosa is good. कुछ नहीं कर रहा तो. See this conical projection, this conical projection. This is all where the tumor is attached to. Can you see?
Yes, sir.
This is all massive tumor attachment. See, this is what you saw on the CT scan. Conical projections.
Right, sir.
Section. Gone. Section जवाब देगा सारे. No section is working. तो दूसरा कर रहा है क्या? इसका लगा दे.
Hello, Dr. Satish sir, in the OT. Hello.
हाँ जी डॉक्टर आनंद क्या कह रहे थे?
Sir, maintain the high volume, high pressure suction, sir.
हाँ हाँ 3 रखी हैं बस.
1 HP suction is also inside the OT. Kindly switch on that powerful suction.
कोई नहीं हो रहा है.
40 debrider. See the area of interest in front of us.
Complete floor is also involved, sir.
We'll see each and every area. Close up.
And the irregular cortical bone which was evident on the MRI and CT was quite clear here in the endoscopic picture as well.
Drill. वो देख सकते हैं लाइट वाले. पानी पानी.
बार बार दिक्कत होती है.
अच्छा. See now.
Do we need frozen in this case also, sir?
क्या बोन में सारा ना.
Sir,
No, no, alveolar arch is below. बस जरूरत है जब ऐसे मत डाल यार. When only the camera is spoiled. Further flushing the medial wall inferiorly.
When do we think to send the frozen, sir, in the operation of the inverted papilloma like in this?
Pardon? Can you speak little louder, Anand?
Sir, in which scenarios and the cases we can think of sending the patient for the frozen section? Suppose this is a recurrent or residual inverted papilloma. So when will you suggest to go for a frozen?
Indication is must. Frozen section is must. Any case of inverted papilloma, you are operating, frozen section is must. See the floor. See the floor here, this side. See, it is not invading any mucosa. See the mucosa normal? That's why I am flushing to rule out. Area of interest is here only. See this? This is all invaded. The large area of the bone is invading. See this?
Yes, sir.
Biopsy forceps. Wash. Wash connected.
Dr. Satish, this lateral valve is involved more,
Yeah.
while this inverted papilloma is more on the medial valve.
No,
Do
it
you
can.
think any differential
It,
diagnosis in this such case?
no, inverted papilloma is quite common on the lateral wall. Quite common on the lateral wall. See this? Now I will focus on the removal of this bone. See this? After exposing it, now the periosteum गिर गया था यार. See this? Separate this. Here. Complete. See the lateral wall involvement? Now I am coming on to the area of interest for radical removal. Drill. डाल पानी. Section. लगा? क्या? इसको छोड़ भी. थोड़ा तो रिटेक कर यार. सेक्शन करना है यार. इसको रिटेक कर दो. पानी ये डालेगा. रिटेक कर अच्छा वाला. यहाँ करना है। See now I am here point डालो section करता I am drilling this underlying bone to remove. This is tumor bone. See this?
Yes, sir.
Now I am coming directly onto the tumor. पानी डालो यार. Guru, fast. Don't do this. This will ruin the entire thing. I cannot see without irrigation. See, I am drilling away this entire projection. पानी डालो यार. इनको दे देगा हाथ में पानी. Irrigation चाहिए अभी यार. Come on. Irrigation. जब तक irrigation नहीं होगा ना, I cannot work. मुझे clean bone दिखनी चाहिए यार. I want this irrigation, man. This kind of irrigation. थोड़ा डालो. I need to differentiate normal from abnormal. And irrigation is the key. See, I am drilling away this bone. पानी डालने का जुगाड़ कर तो कोई यार. धार वाला. धार का जुगाड़ कर. पानी की धार. See the tumor vessel in the bone. See the tumor vessel.
Yes, sir. Visible, sir.
सब लेते हो. कॉटरी भी रखेंगे नहीं. See the main tumor vessel. छोड़ो. पानी रखना है यार. तू पहले तेरे जुगाड़. See this tumor?
Yes, yes, very well seen. Out it is.
This is the most representative part of the tumor.
That vessel is still pulsating.
See, there is huge bony involvement still. अभी तो शुरुआत हुई है वॉश देखो बिना के वॉश क्या कर ऑन डिमांड चल रहा है रुक जा कब लेटर वो निकला ही नहीं था it was not completely removed actually that was not लेट आता है सेक्शन तो कर दिख नहीं रहा है तो धार बन के जो देखना चाहता हूँ ना मैं कब लेटर infraorbital canal was invaded. See this? Drill. So we are at a very, very critical area. हटा ये रखो इसको गुरु यहाँ लगाओ यहाँ लगाओ
Right angle retractor we are using now.
नहीं just periosteum elevator. That's it. नो पकड़ो कब लेटर देखो drill. See this? The most hidden areas. पानी डाल उसके ऊपर डाल बोलूँगा नहीं मैं कर डाल दिया चाहिए ना yes yeah no I floor of the orbit I am away no worries okay. This is clean area. This is the lateral recess of maxillary sinus. It is known as that hidden area. See, this entire lateral part was so deeply invaded. This requires drilling, drilling and drilling. Come later. See how this part of the bone was invaded. See the underlying bone?
Yes, sir.
See this upper part? Come later. See this upper part, how it has been cleared off?
Yes, sir.
Thin bone can be left which has no aversion system to be invaded by the tumor. Rest all thick bone has to go until you are very, very sure about. No, अब धीरे धीरे धार बना. धार बना. धार देखिए. हो गया. वॉश तुरंत. मेरे को वो चाहिए. समझ नहीं रहा. वही दे अपने वाली. See the area of attachment. Below. We have to ensure all possible ways that no bone, no invaded bone is left. Drill.
Now, sir, will be clearing inferiorly?
Pardon?
Sir, will be clearing the area inferiorly?
Yeah, inferiorly, there is a lot of area left. Can you see the good bone now? ओए यार मेरा फील्ड मत खराब करो यार. कौन डालता है? With time, with experience, you get to know which is invaded bone, which is bad bone, and which is normal bone. This is invaded bone. इसके ऊपर डाल दिया कर. इसको सेक्शन कर ले. Is the vessel which is supplying. Again. Tumor vessel. दिखाना यार. यहाँ लगा लो. हाँ. See the superior part.
Yes, sir.
करो उधर करो. पानी कम कर रहा है. ये थोड़ा उछलता है. ये देख.
ड्रिल का पानी थोड़ा सा कम कर दो.
और एक हाँ 25 ठीक है. आ जाओ. Debrider. Watch ना मेरे को कर्ड में आ रहा है. See how the bone is infiltrated. Section. Without removing the underlying bone, operating on a papilloma is a joke. Debrider. This is the mucosa now. हटाओ सक्शन नहीं चल रहा. हाँ that is normal. वो यही है. This looks so. अरे ये भी बंद है यार. See, no attachments here, just bad inflamed mucosa, not bad at all. See this? This area, we knew it. That is not the site of attachment. This is infratemporal fossa wall. And this is your infraorbital nerve compartment which was affected, and I, you know, इसला cobbleter there. This was not the area of interest, just bad mucosa. खोल इसको. So we have to check each and every area again. ये देखूंगा अभी. ये that was not affected. This is the cut edge of the. This is the nasolacrimal duct and this is mucosa, simple mucosa. We knew when we elevated from inside the nasal side, this was free cobbleter. See, the things dramatically changed. छोड़ना.
How many days do we keep the pack for this?
2 days.
Any special post-op?
कुछ नहीं. Give some antibiotic. Start dosing after 2 days. Nothing. Suction नहीं चल रहा इसका यार. बिना suction is useless. Rider covered. Hello.
Hello. Yes, please.
See the interior of the maxillary sinus.
Laterally, is it still you have some doubt?
Yeah, I will flush further. No, grossly I have removed the disease. Grossly, no, rather microscopically also from everywhere. See this?
Yes.
But I have to do something to the underlying bone. See this? How much the bone was drilled. It was deeply infiltrated for more than a centimeter.
Long pack of roll gauze or narrow pieces?
Roller gauge, soaked in betadine. इसको retract करो, इसको retract करो. Retract this. दिख ही नहीं रहा.
Anything more or this is fine?
Pardon?
The frozen comes positive for the malignancy. Do we need to do anything more or this thing will suffice?
Yeah, had this been malignancy, proven case, I would have removed this underlying bone also as a margin.
Whatever frozen sir, if that is positive.
Yeah, frozen section would have been a great help. The MRI picture, I don't know when it was done, whatever, are not showing any necrosis. Suction karo yaar, irrigation karo. My whole thing depends upon suction and irrigation. I become blind.
Sir, if post-op
Dhar bana.
histopath comes positive, then
Pardon? Sir, there is a lot of noise. Can you speak little louder?
if the biopsy comes positive for the malignancy, then do we need to go for revision surgery or the radiotherapy?
In this patient,
Yes, sir, in this patient.
if biopsy turns out to be radiation malignancy, I will come back and remove this lateral and posterior wall. That's it. And send for radiation therapy. That's why frozen section is critical. Though my gut feeling is not looking malignancy. I am taking the feel of the underlying bone. Infiltrated necrosed bone has a different feel. इस पे डाल कैमरा पे यार.
Hello.
Yes, I am the last part.
Sir, how do you determine till what depth you have to drill the posterior wall?
Yeah, till I find the papery thin bone, transparent bone.
Okay.
That gives you the idea that the bone is no more thick bone is left. No vasculature, no bones seemingly involved. See this absolutely thin bone.
Yeah, I can see.
That assures you that no underlying bone infiltration is left. I am pretty radical on that. See, all no tissue is coming, no vascularity, all normal. See the kind of bone there.
Yeah.
See, it was this area only which was involved. See this one? See the kind of anterolateral wall I have removed. This medially, there was no tumor attachment. This was just occupying. In the medial part, there was no attachment at all.
Hello, sir. It's almost finished.
Yes.
Surgery almost finished.
See the whole maxilla now. Looks. See, the bone has become so thin now. This. Come later. सक्शन कर लो. तो चल ही नहीं रहा, ये तो चल ही नहीं रहा. देखा. See the final picture. Look at the final picture of the bone. See how it was conical projection, how deeply infiltrated. Outside tissue is normal. Give me coagulator. वो हटाना इसको. So this is all about, I'll just achieve the hemostasis outside and call it a day. The coagulator. See how useful are the tools in endonasal surgery. Drill, coagulator, debrider. No tumor. I have a feel of tumor bone. See this? All normal bone now.
Sir,
Yes, please.
what do you do to prevent crusting in this sort of cases post-operatively?
Douching.
Okay.
Regular, sometime crust removal to facilitate mucosal healing.
For how long, sir?
This will take 6 to 8 weeks to completely heal.
Okay.
The best part is with this approach, the follow-up is much easier. You don't need scan. See this? The entire maxilla has been flushed.
Yes.
No question of leaving behind. This is the, above is the infraorbital canal, which I have also drilled away. And this is the area. This is the area of interest. See this? Not inferiorly, not medially, not superiorly. This is the area. And absolutely clear. Thank you very much for your attention. Any questions left?
No, sir. Thank you so much.
Thank you.
कैरोटिड सब एक्सपोज कर देते हैं सर, पूरा बोन को एक्सपोज कर निकाल के.